Hello, today we're going to be talking about perfusion. As you can see, there are 5 different exemplars. And so today we're just going to be talking about myocardial infarctions. But make sure you look at all of the content listed for this week. Look at the objectives and directions. I put on there what you should watch prior to class, and then what you can watch after or do after class. And then what we'll be doing in class. So hopefully that is helpful for you. So when we're looking at perfusion, specifically blockages, I want you to think of a roadblock. So if we have something that's blocking the road, the goal is to restore flow or restore perfusion. So we can either remove the blockage or we can reroute it, just like we would do with construction. If the road's closed, we reroute it, right? Or we can remove it, repair the road, and then flow is restored. So with removing, we're thinking thrombolytics or a percutaneous intervention, placement of a stent, which we'll talk about later. Thrombolytics, we're breaking up that clot or that blockage. With PCI, we're making a path to remove that blockage. With rerouting, we're looking at a coronary artery bypass graft, in which we are rerouting the traffic or rerouting the blood flow to a particular area of the heart. So keep these in mind as we're going through things. Think about blockages, road traffic, and how we restore flow. So more specifically, we're talking about myocardial infarctions, also known as a heart attack. So as you may recall, you talked about acute coronary syndrome. Coronary artery disease can lead to acute coronary syndrome. And in this course, we were focused on emergent situations. So with this, angina occurs with an expected stressor. Unstable angina is not predictable chest pain, typically occurs at rest and increases with intensity as time goes on. The plaque in the coronary artery ruptures and causes a thrombus formation and limits or completely occludes blood flow to the heart muscle itself. So you can have a partial occlusion or a complete occlusion. At the cellular level, the heart muscle becomes hypoxic within 10 seconds of the coronary artery becoming occluded. Ischemia or death quickly follows, and irreversible damage occurs after 20 minutes of occlusion. So ischemia means lack of blood flow, which causes damage to the heart and occurs within 20 minutes of occlusion. If reperfusion occurs before that 20-minute window, then aerobic metabolism resumes and cellular repair begins. So keep in mind the differences between unstable and stable angina, and again, what that looks like for the patient. So we can classify things into 2 different categories. You've probably heard the term STEMI versus a non-STEMI. Which would classify STEMI with ST elevation indicated on the left here, and a non-STEMI can be present, but usually is signified as ST depression or non-ST elevation. So a STEMI occurs because the right main or the left main coronary artery, which is the most common place, is 100% occluded. This occlusion causes an ST elevation on the EKG strip, as you can see on the left. This is a medical emergency. You've heard time is muscle. So this is what we're referring to. Patients need to be in the cath lab within 90 minutes of seeing this on the rhythm strip. We'll talk a little bit more about later. One of the earliest actions is to administer thrombolytics. Remember, thrombolytics is a goal to remove the clot or break up the clot to assist with restoring flow. So one of the thrombolytics that could be used is TPA. A non-STEMI occurs when there's a thrombus in the main coronary artery, but does not occlude the artery 100%. So this would be a partial blockage. The rhythm may show normal rhythm or an ST depression, as you can see on the right. This is also an urgent issue as it may progress to a STEMI if left untreated. So we have a partial occlusion. Now this could progress to a complete occlusion. And so treatment is urgent and needs to be implemented within 3 days. So STEMI, 100% occlusion, non-STEMI, partial occlusion. Here we have a 12-lead EKG, and you can see that there is ST elevation in the circular portions there. A 12-lead EKG is required in the first 5 minutes of the patient reporting new onset of acute chest pain. An EKG must be read by the ED physician within 10 minutes of patient arrival. If EMS is bringing the patient in, an EKG is usually transmitted prior to arrival for the physician to read. This speeds up the process, of course, of how we can initiate treatment with that patient once they arrive. So, EKG is transmitted, the physician reads it. Is this a STEMI or is this a non-STEMI? If the patient is having a STEMI, the lead that shows the ST elevation can help determine which artery is occluded. We'll look at this on the next slide a little bit more closely. But leads with the ST elevation in V1 through V4 present in this picture indicate an anterior wall infarction left main coronary artery. If ST elevation is in 1 through 3 or AVF leads, it's a posterior wall infarction, the right main artery, which is less common. So I don't expect you to know just by looking at these EKGs which artery is occluded, but I want you to know how this information is gathered. So here's a diagram or picture I found that I think is very helpful. So there's an acronym when you're looking at a 12-lead EKG. As you go down, you see leads 1, 2, and 3. So you have LII, or a big lie. Then you have AVR. I can't read that one. And then AVF, a little lie. And then SSA, or ASS backwards. And then ALL. So the acronym goes big lie, little lie, ASS backwards, all the time. And as you can see, that helps you indicate where the blockage would be. So if you have ST elevation in leads 2 and 3 and AVF, you know that it's inferior. Inferior STEMI patients with RVI vitals are typically in their boots. The picture looks like a boot. You may have heard the term widowmaker. Elevation in leads V1 through V4 and affects the entire left anterior descending artery, which is the largest coronary artery of the heart. So if there's a blockage in the LAD, usually the prognosis is not great because that's a large artery that perfuses the heart. So of course there's going to be more damage that way. So hopefully you find this helpful. Again, I don't expect you to know all the specifics, but I just want you to know this is how you would draw out the 12-lead EKG to find out where that blockage would be. So symptoms for these patients typically are on the spectrum as far as pain. It can look different in everyone. If any of you work in the ED, you know that some people come in and they say they just thought they had acid reflux. It didn't feel like a heart attack at all. Other patients, you visibly see that it is crushing feeling, severe pain, heavy, tight pressure. That's how they describe it. So it can vary from person to person, and females especially have kind of some vague symptoms that don't always look like what you'd think would be heart attack symptoms. So patients often describe it as a heavy pressure, tight, burning, or constriction, crushing feeling, and they can also often have it in the epigastric and substernal areas. Pain may radiate to the neck, lower jaw, arms, or back, and the pain continues to increase despite actions to relieve pain. So some patients may feel like they have severe heartburn that is unrelieved by Tums. Heart cells will release norepinephrine and epinephrine in response to the ischemia. So therefore, their heart rate and blood pressure increases. Remember, norepinephrine and epinephrine are vasopressors. They constrict those vessels and pushing blood flow back to the heart, which would increase their heart rate and their blood pressure. This also causes diaphoretic and cool and clammy skin. You would also hear abnormal heart sounds because of poor perfusion. Nausea and vomiting can occur because of the vagus nerve reflexes that are connected to the heart muscle, and sometimes also stimulates that response due to severe pain. Fever also can occur from the systemic inflammation response. Table 33.14 has a good, some good descriptions for you, so I'd encourage you to take a look at that. For diagnostics, of course, like we talked about, your EKG should be done in the first 5 minutes to detect a STEMI or a non-STEMI, which they would be treated differently. Troponin levels will be ordered stat as they are the best biomarker for diagnosis of an acute MI. Troponins are proteins that are released into circulation because of necrotic heart muscle. So these levels will increase after 4 hours, peak around 12 hours, and the majority of protocols will require troponin levels to be drawn Q6 hours for 3 times. Troponins typically take about 10 days to 2 weeks to return to normal, or less than 1. Your textbook talks about 2 subtypes. I do not expect you to know the difference in these subtypes. I just classify it altogether as troponin levels. So on that graph here, you can see troponin I and troponin T. I just want you to group them together. Typically, they will increase after 4 hours, peak around 12, and then decline, take about 10 days to 2 weeks to return to normal. So this is also the best biomarker for diagnosis of acute MI. CKMB is another biomarker protein that is specific to the heart muscle, but it's not as sensitive as troponins, so it may or may not be drawn. It does increase at 6 hours and peaks around 18 hours, and then it returns to normal after 24 hours. So you can see that red line on there is your orange line is your CKMB. Again, it is not as specific as troponin. Myoglobin is the first protein to increase, but it increases with any muscle damage. So it is not necessarily specific to heart muscle. So remember, myoglobin is non-specific. It does rise after 2 hours and peaks within 3 to 15 hours. Emergency protocol actions. So after we've obtained our EKG, we're going to set the patient upright, gather their vital signs, of course, assess their pain. Remember PQRST as part of your assessment. Once we've obtained their 12-lead EKG, then we're going to place them on continuous EKG monitoring and have the physician read that EKG within 10 minutes of patient arrival. As far as the ED goes, if you're on the floor, you're going to take it, send it to cardiology to have it read stat, or physician cardiologist for the patient. We're going to auscultate their heart and lung sounds, obtain labs. Remember our cardiac biomarkers that we just talked about. Within 24 hours, Leukocytes can infiltrate the area, so we would see a high white blood cell count. So that is normal. Also, with an infarction, we can see elevated glucose levels, so we would also get our CBC, BNP, and coagulation labs performed. We'd also obtain a portable chest x-ray to rule out any other causes of chest pain, such as pulmonary edema, trauma, anything else that could cause chest pain. Also, we want to assess for contraindications for this patient. So, if they have any contraindications for antiplatelets, anticoagulants, thrombolytics, or for the cath lab, i.e. iodine or iodine allergies or shellfish allergies to contrast dye, they would not be a candidate for the cath lab. And then we also want to start 2 IV catheters. Usually these are large bore catheters of at least a 20 gauge. Next, we're going to talk about emergency protocol meds. So I don't know if you've heard the term MONA. That's a good acronym to remember: morphine, oxygen, nitro, aspirin for your chest pain patients. So oxygen, usually we'll put them on nasal cannula or a non-rebreather to keep their O2 sats above 90. Aspirin will be given usually by chewable tablets, 160 to 325 milligrams. So 81 is a baby aspirin, 325 is a full aspirin. Nitro, or nitroglycerin, we're going to give 3 tablets, usually sublingually first, 1 tablet every 5 minutes until IV nitro is prepared. So nitro decreases the preload and afterload while increasing the oxygen supply to the heart. Common side effect of nitro is hypotension, so we need to be aware of this and watch for that. So we're giving these patients nitro while they're having chest pain every 5 minutes as the chest pain continues until IV nitro is prepared. Morphine, it's a vasodilator. This is going to lower the oxygen consumption by the myocardium, reduces contractility, decreases blood pressure and heart rate. So we want to monitor for bradypnea or hypotension. Thrombolytics. Remember our TPA. This is only for patients with a STEMI or complete blockage. Helps dissolve the clot and reperfuse the heart. TPA must be given within 30 minutes of patient arrival, and it's administered slowly over the 30 to 90 minutes, assessing for changes that may indicate cerebral bleeding. So we're breaking up this blood clot, and we could have them go the other way, right? So we want to stay at the patient's bedside, monitor their heart rhythm, their vital signs, pulse ox, heart and lung sounds, assessing for bleeding, and the response to therapy. So what are some signs that TPA is causing a bleed? Well, we could see a drop in the blood pressure, increased heart rate, sudden change in mental status, blood in the urine. If any of these signs are present, we would call the MD immediately. If reperfusion occurs with use of these thrombolytics, the ST segment should return to baseline, and the patient should have resolution of chest pain. Another thrombus could occur and reocclude the artery, so patients will receive heparin and should be at a facility with percutaneous intervention capabilities or cath lab abilities. If thrombolytic therapy fails, of course, they get a ticket to the cath lab. We can also give these patients high-dose statins. Atorvastatin is an example. These are lipid-lowering and antidysrhythmics. So on page 711 of Lewis, figure 33.5 is a great overall picture of assessment and management of these patients with angina versus acute coronary syndrome. So I suggest you take a look at that. So again, these patients must be in the cath lab within 90 minutes of a confirmed STEMI, complete blockage. A catheter with a balloon tip is most commonly inserted at the site of the femoral artery and is threaded to the site of the coronary blockage. The deflated balloon is positioned against the blockage and inflated to compress the plaque against the artery wall. This is called a balloon angioplasty. A stent can then be placed to keep the vessel open. It's a mesh-like structure that you see in the picture here. They can be bare metal or drug-eluting, which will limit overgrowth over the stent. So again, the balloon is inserted, pushes the plaque up against the wall of the artery, and then the stent is placed to keep that artery open. Stents can be risked for clotting, so often these patients will receive unfractionated heparin or low molecular weight heparin during the catheterization procedure. Following this, the patient receives dual antiplatelet therapy. They'll be on aspirin indefinitely, so taking an aspirin for the rest of their life. And then they will also receive Plavix as an antiplatelet therapy. If an angioplasty cannot be completed at the time of the catheterization, an emergent coronary artery bypass graft is required, which we will discuss later. For post-emergent care, there is a metabolic process that occurs for patients recovering from a heart attack with the necrotic tissue that's created from the infarct. Macrophages and neutrophils come to clean up the mess behind. So about 10 to 14 days later, the heart muscle has developed some scar tissue. The leftover healthy heart muscle then tries to compensate for the damage area by enlarging and dilating. This is called ventricular remodeling, which can cause heart failure. So ACE inhibitors are given in recovery to help reduce this. As far as positioning goes, the heart works less when we are sleeping or resting, so we want them to have a calm, quiet environment, and then lots of sleep is encouraged. We do monitor the cath site very closely for the first hour and notify the MD if any hematoma were to develop. Patients are also at risk for developing VTAC or VFib after an MI. So these patients are going to be on tele or telemetry, and we want to notify the physician if there is a frequency in PVCs, which could potentially lead to one of these fatal dysrhythmias. As far as meds go, we talked about ACE inhibitors. They also would be on beta blockers, antidysrhythmics, lipid-lowering agents, stool softeners. After heart checks are given because these patients are prone to fatal bradycardia issues when vageling or straining. So stool softeners help prevent that. Also, these patients may exhibit anxiety or fear after this life-threatening event. So we would implement anti-anxiety interventions, provide them with some SSRIs or benzos as appropriate to help with this. For cardiac meds, table 33.12 is a great reference for you. So take a look at that. Please post any questions you have over this content on the discussion board so that I can relay the information to you in a timely manner and so that everyone can see the information. Thank you.